Welcome. My name is Brittany Kimball.
I'm Talitha Wilson.
And
I'm
today, go ahead.
Oh, and I'm Will Matchett.
Today we're going to be talking about unpacking vaccine hesitancy in the era of COVID-19. And Talitha and I are going to be presenting, but we also have a third panelist who is Will Matchett, and I'll let him introduce himself real quick and his background, and we'll introduce ourselves during the presentation.
Thank you. Yeah, so as Brittany said, I'm Will Matchett, and I'm a postdoctoral researcher here at the University of Minnesota. And my PhD and my postdoctoral research work is focused on vaccines and vaccine development. And specifically in my postdoc, I've been working on development of a COVID-19 vaccine. And so I hope that I can provide kind of a scientific perspective for any questions that may arise.
So he's mostly going to be focusing on answering any questions, particularly scientific ones that come up. So our objectives today are to talk, number one, about the historical trauma that contributes to vaccine hesitancy. Number two, to talk about some of the common reasons that people are concerned about the COVID-19 vaccine in particular, and address some of those questions. And then third, talk about strategies to address vaccine hesitancy and advocate for vaccination. So who are we to kind of be talking about this at all? Well, I'm Brittany, and I'm a third-year Med-Peds resident. I previously worked as an AmeriCorps volunteer in the Cedar Riverside and downtown Minneapolis neighborhoods. And as part of that work, did a little bit with the Department of Health when they were doing vaccination efforts, particularly through mosques and education through that in the Cedar Riverside neighborhood. And I also am a former bioethics researcher, and Will is my partner, which is kind of what brought him here today.
And I'm Talitha Wilson. I'm a second-year Med-Peds resident. I used to work for the CDC, the Centers for Disease Control. My work focused on infectious disease, surveillance and management, particularly sexually transmitted diseases, and I worked in Miami, Florida. And as an aside, I grew up in a small town in Alaska, so I have some perspective on the challenges of rural medicine.
So to start, why are we talking about vaccine hesitancy at all? Well, this was a survey that was done back in April, asking people, before, at this point we had no vaccine yet, but asking people, when a vaccine becomes available for coronavirus, would you want to get it? Almost 60% said yes, 10% said no, absolutely not, and about 30% just weren't really sure. These numbers have changed, and actually more people are willing to get the vaccine now as more information has come out, but there continues to be a large portion of people who just aren't sure and have questions about the vaccine. So we wanted to ask folks at Kook what their feeling was on it. So we asked if a free vaccine was offered, would you get it? And about 12% of people were either definitely didn't want to get it or potentially didn't want to get it. So you can see there's a lot of people with concerns, and that's what we're hoping to address today. When we asked why people didn't want to get it, if they had concerns, some people were concerned about the speed that it was developed with. Many people were concerned about side effects and safety, and then some folks didn't feel like they needed it. And so we're going to focus on kind of all of those things today. But before we get to specific concerns, I want to take a step back and talk about why people might be hesitant when it comes to a new medicine or vaccine in the United States. Well, unfortunately, we have a history of several problematic historical situations that have made particularly marginalized communities skeptical of medical research and vaccines. And that history continues through today. These are not the only examples, but I wanted to highlight three fairly recent historical examples. In 1932, the US Public Health Service enrolled African-American men with and without syphilis into the Tuskegee syphilis study without informed consent. They did not inform the men of their diagnosis of syphilis, and they trialed ineffective and sometimes even toxic treatments on the participants. The study continued for 40 years, even after penicillin was developed for treatment, and they never informed the participants that they had a curable illness. And this might seem like a long time ago, but this study actually continued through 1972, which is fairly recent. In 2003, it was brought to light that DNA samples from members of the Havasupai tribe were being used by Arizona State University for research without consent. These samples had been obtained from tribal members under the guise of diabetes research, which was something the tribe was interested in. But they were actually used for several other things. Researchers were looking into several things that the tribe did not want looked into and did not consent to having looked at. And it wasn't until someone from the university connected to the tribe actually found these samples and realized that they were being used kind of beyond the informed consent process that anything was done about it. And then in 2011, the CIA led a hepatitis B vaccination campaign in Afghanistan to collect DNA samples in order to identify family members of Osama bin Laden. And they actually used a real vaccine, and Hep B is a problem in that region. But what they did was they collected the syringes after vaccination, and then without anybody's consent, obviously, studied those in order to try to identify members of Osama bin Laden's family. And that ultimately led to finding some people and ultimately finding Osama bin Laden. And this has caused huge problems with vaccination campaigns because people are rightfully fearful about what the real purpose of any particular vaccination campaign might be. So this historical trauma is then complicated by vaccine misinformation that's all over the news. And these things come together to form a really powerful reason for people to be hesitant. I'm not going to belabor this because most people are aware of this story, but this is Andrew Wakefield. He wrote about a false association between MMR and autism that has been repeatedly proven incorrect. His paper was retracted. But he continues to be a force for vaccine misinformation and even spoke with members of the Minnesota Somali community and spread this misinformation here. Further, there's many celebrities that are involved in vaccine misinformation and spreading that, and those things come together to make people really nervous. So those are some of the reasons why, kind of the historical reasons why misinformation spreads and then why people might be wary of this. But I want to kind of pivot to some of the specific things people are worried about with this COVID-19 vaccine. And what I want to highlight here is there's a group of people, a small group of people who are never going to want to get vaccinated. And that's not really who we should kind of aim our advocacy efforts for. There's a large group of people who are just concerned and worried and kind of could go one way or another and really just needed more information before they're willing to put something in their bodies. And I think that's the group that we are most focused on targeting here. So one major concern that people have is that the vaccine development process was rushed. And I just want to highlight that it was really new technology that allowed the vaccine to be developed so quickly. So there was a body of previous SARS virus research work to build on. And there was also a body of mRNA research work that had been developed, but hadn't necessarily had a particular application yet. Prior to this, in the past, new vaccines took a lot of time to develop because you either had to attenuate a live virus or create an inactive version of the virus. And then you also had to spend a lot of time trying to determine adjuvants to stimulate an immune response. But we'll talk a little bit more about the technology in a minute. And actually, there's going to be a completely different presentation all about the mRNA technologies. But suffice it to say, it kind of averted these two steps and meant that we could move very quickly towards an effective and safe vaccine. But the important thing to remember is that the vaccine still had to go through all of the typical steps required for approval. So the back end science was quite sped up, but the actual process for approval, it had to go through all of the usual steps. These are the steps required by the FDA to get something approved. And I think the point here is that starts with a small group of people that the vaccine is tested on to make sure that it's safe. Then it moves into further phases where it's tested on more people to make sure that it's safe and effective. And typically this process takes many years. But in this case, there was a ton of money that was invested to have each step completely ready, and assumed that each step was going to be successful. And that's what was also different, is that there wasn't like a lag time between the phases. And that's part of what made this available so quickly.
Okay, and so one of the biggest questions that people have been asking is a big concern: is this new vaccine technology, mRNA, safe? And so the short answer is that, can you click through there? Yes, the new vaccine technology is safe. So the United States Food and Drug Administration, the main governing body in the United States that makes sure that our prescription medications are safe for people to use, has determined that the COVID vaccines are both safe and effective. So specifically, what does this mean? So as Brittany alluded to, this technology has actually been studied for decades in other viral infections and other coronaviruses. So they were able to apply that technology to develop these new vaccines. This new vaccine is different than live vaccines. So there is not any weakened form of the virus within the vaccine itself. The vaccine is free from materials of animal origin. It's a cell-free process, and there's also no preservatives inside of the vaccine. And then thinking about how this vaccine was tested, it included trials, both with the Pfizer and the Moderna vaccine, combined over 70,000 people in these vaccine trials. And they were followed for about 2 months. And that does sound like a short amount of time, but actually it's a longer span of time than what we see is usually the window of time when people have side effects from vaccines. Okay, so here is another concern that has been brought up, particularly in social media. Can the vaccine cause genetic changes? So no, the vaccine actually does not enter the nucleus of the cell. And you can think of the nucleus of the cell as the brain of the cell. So that's where our DNA is kept. So number one, there's no effect on a person's genetic makeup. And number two, you do not get infected with the COVID infection. So how does this really work? So I'll just provide a brief overview, and then there'll be that presentation next week to talk more about how the vaccine actually works. But mRNA stands for messenger ribonucleic acid, and that's a bunch of long words that really means it provides instructions to our body. So you can see in this image on the bottom, the mRNA is made up of instructions to make a specific protein on the virus. It's called the spike protein. That's part of how the virus gets into our body and causes the infection. The mRNA is inside of the vaccine, and once it's inside of our bodies, it goes into our cells and teaches our body with these instructions how to produce the protein. And then our body is able to fight off the infection. It teaches our immune system. And once this process is completed, our body does an amazing job at breaking down these instructions so it doesn't linger in our bodies. So another big concern is that, will this vaccine affect fertility? So the answer is that no, there is no evidence that the vaccine affects fertility. Specifically, the American College of Obstetricians and Gynecologists, that's the main physician advising body in the United States that provides guidance about fertility, pregnancy, and lactation. And they have released a statement that says, based on this mechanism of action of the vaccine, as I explained previously, and the safety profile in non-pregnant individuals, it does not affect fertility that we know of.
So to build on that, this is a concern that a lot of people have, is just, is this safe? Is this vaccine, even beyond fertility, is it safe for pregnant patients? And And the American College of Obstetricians and Gynecologists have put out several statements on this, which are really helpful. And I think the biggest piece that they highlight is to take a step back and look at the risk of COVID-19 infection in people who are pregnant. And people who are pregnant, when they get COVID-19, they're at increased risk of more severe illness compared to people who aren't pregnant. This means they're at higher risk of needing an ICU admission. They are at higher risk of needing mechanical ventilation and even ECMO, and they're at higher risk of death. So the risk of infection is incredibly high. That said, the vaccines that are currently available under the emergency use authorization haven't been tested in pregnant women. Therefore, there's no specific safety data in pregnancy. All of that said, there is nothing about this vaccine that would make us necessarily concerned about pregnancy. In particular, live vaccines are not safe for pregnancy, and this is not a live vaccine. So ACOG recommends that COVID-19 vaccines should not be withheld from pregnant women, meaning that pregnant people should be able to get the vaccine if it'd be recommended for other reasons. And the biggest reason is because the risk of having COVID itself is high. And they also recommend that the vaccine should be offered to people who are lactating and breastfeeding as well.
So another concern that is critically important to talk about and to be thinking about is that question about being undocumented, and will COVID vaccines be used to gather people's information and be put in a national database to be used by immigration officials? So the answer is that this is state dependent, unfortunately, as states are controlling vaccine distribution. What we do know so far by limited information released by Minnesota state officials is that the Minnesota Department of Health has said that they will only be sharing the date of birth, the county, and vaccine information to the National Data Clearinghouse. And it's really important to stress that state privacy laws do and should protect this data. And I think that there will be more information released and assuring our communities and our providers, as this is a high risk population, that we want to make sure have equitable distribution and receipt of the vaccine.
You're muted, Brittany.
Thank you. Another thing people are worried about are vaccine side effects. And so I just want to talk to you a little bit about the common side effects of the 2 COVID vaccines. Pain at the injection site is the most common side effect. The other thing that's common is symptoms of having an immune reaction. And those are fever, chills, tiredness, and headache. And they're more common after the second dose. So this is a 2-dose vaccine series, and you're more likely to have those kind of immune type side effects after the second dose. Those are they do not mean you have COVID infection. They're just, I like to tell patients, it's kind of like your body practicing for infection. They're typically occurring within 7 days of getting the vaccine. Another thing people are concerned about are the allergic reactions, which can occur. That said, they're incredibly rare. People who have a history of anaphylaxis can still get the vaccine. The only people who shouldn't are people who have a history of anaphylaxis to one of the specific components in the vaccine. And we're monitoring everybody after they get the vaccine. So if you've never had any sort of reaction, anaphylaxis before, the monitoring period is 15 minutes. And if you have had anaphylaxis ever to anything, then you should be monitored for 30 minutes after getting the vaccine. And every site that's providing the vaccine has supplies to manage any reactions that occur. This is just to give you a sense of how common the different types of side effects are. And I think the thing to really warn patients about that's most common is pain at the injection site. A lot of people talk about having a sore arm after this vaccine. So I think just letting people know that that will likely occur might be helpful for them. I think another thing people are concerned about is long-term effects of vaccination, since we're only, a number of months out of testing this. And the most important point here is that the important vaccine side effects occur within 6 vaccination, and we have that data. So I think you shouldn't be really concerned about long-term effects of the vaccine.
And so now we'd like to pivot to where we go from here. So we'd like to talk about strategies to address vaccine hesitancy. And we're going to talk about 7 different strategies because it's definitely not a one-size-fits-all subject. And so I just put this image here to illustrate how we're going to start big and go small. So we'll talk about strategies on a societal level and a community level, and then focus on more on an individual level in a clinic, what we can do to address vaccine hesitancy. So probably the most important thing that we can do as patients and as providers is to be educated with science-based information. And so I want to highlight 2 different specific education initiatives that I think are critical. One of them is from the Minnesota Department of Health. There's specific vaccine training. And for those of you who are listening who are from Kook, that is actually a required training. So check your email if this doesn't sound familiar to you. The other education initiative is that there's a CDC website also that has a web-based training course for the COVID-19 vaccine. And then at the bottom, I included some other information briefly, just to show that one of those is the Pfizer information about the vaccine is in many different languages, including Somali, which is a big population that we serve. And then I also included this GIF from the CDC website. It's about the flu, but I think that CDC does a great job providing patient-friendly language and information. And I think it's just a matter of time before more information comes out about the COVID vaccine. So more to come on that. So the second strategy we want to discuss about sort of population level vaccine hesitancy, what can be done. And so it's the concept of mandated vaccination. So just to provide a little bit more information for those who are unfamiliar, the government can impose coercive policies for mandatory vaccination. So what this means is that governments can withhold freedoms or benefits and enact penalties for those who do not follow vaccination mandates. An example of this would be that in the past, before COVID, the flu vaccine was mandatory for people working in hospitals, and hospitals could mandate people that didn't get vaccinated that they had to wear, masks for the entire flu season as a penalty. Or another example would be getting vaccinated in order to have entry into public schools for kids. I would say that mandates could be more punitive to disadvantaged groups who face barriers to vaccination, particularly if that was done on a state level. But some public health experts have speculated that healthcare institutions like hospitals may enact COVID vaccine mandates, although no state has yet, I have not heard of that actually happening. And so thinking more on a community level, what we can do about vaccine hesitancy is make it more easy to get the vaccine. And so one strategy is to incorporate pharmacies as ways of delivering the vaccine to our communities. So it's actually pharmacies are widely available to people, that 9 out of 10 people live within a 5-mile radius of pharmacies. And people actually already use pharmacies a lot to get vaccinations. And about 25% of people are already getting their flu shot at their local pharmacy. So this means increased access. It's way more convenient potentially, as with longer hours than a healthcare office, and probably less barriers and less cost. And I included this news title that showing CVS and Walgreens, so commercial pharmacies, are partnering with the state of California to offer COVID-19 vaccines to long-term care facilities. So as leveraging many different aspects of healthcare and healthcare delivery to increase vaccination. And thinking more on a smaller level, that partnering with faith leaders and other community leaders could be incredibly helpful to address vaccine hesitancy. And the Minnesota Department of Health actually has a big history of this. So in the 2000s, the Mayo Clinic, as an example, worked with a community center for East African immigrants. And that was a group that was working on literacy. And the Mayo Clinic helped form focus groups to discuss perceptions of tuberculosis. And testing and treatment rates actually increased significantly. Another example is that in 2017, the Minnesota Department of Health and Children's Minnesota partnered with imams during the measles outbreak. They helped advocate for vaccination and provide science-based information to the Muslim Somali community. And now, in the era of COVID-19, community leaders are part of the Minnesota Department of Health task force, helping guide treatment and testing and vaccination in the state of Minnesota. And so I just provided several different images here of the numerous different organizations that the Minnesota Department of Health is partnering with in order to engage and connect with communities of color, culture, and gender to form connections and increase outreach in our communities.
On the theme of just making vaccines easier to get, and something that can be done on a clinic by clinic basis, is using standing orders and nursing protocols to improve vaccination rates. This has been a proven approach that really helps more people get vaccinated by just making things easier. So you can have standing protocols that healthcare workers, other than providers, can assess vaccination needs, give vaccines, and reduce any missed opportunities. So someone who's coming in, say for some other type of visit, maybe it's like a therapy appointment or something else, could also get their vaccine. Cook has standing orders for influenza vaccines and is working on getting these in place for COVID-19 vaccination as well.
And so our sixth strategy to discuss is on an individual level. If you're in a clinic visit, how can we talk to patients about the COVID-19 vaccine and really vaccines in general? One strategy that's been that's on the CDC website to try, that's been shown to be effective, is called presumptive yes communication technique. So what this means is that verbally you come into the appointment with the presumption that people will say yes to the vaccine. That's really just a phrasing of how you talk to people. So the first step is to assume that people will vaccinate. So you say, you're due for the flu vaccine today, or you are due for the COVID-19 vaccine today. And so if people are open and ready for that, then you can give them the vaccine. If people are hesitant about that, then the next step would be to give your strong recommendation. So I would strongly advise you to get the COVID-19 vaccine because the COVID-19 infection is incredibly deadly. And so if from there you can give the vaccine, or if there's still more specific concerns, it's really important to listen and to address the specific concerns that people have in order to allay fears and really answer questions that people have about this new vaccine. And from there, hopefully through the strategy and with patient-centered language, you can form connections and rapport with people. And if you can't vaccinate them during that appointment, to think about how you can set the stage for the next appointment to rediscuss it.
This seventh tool is called the CASE method. And this is really a tool for people who are a little more hesitant and concerned and open to conversation about a vaccine. So step one is to corroborate. So that is to understand where their concern is coming from and kind of come to some shared goal together. The second is to provide a little bit of substance about who you are and where you're coming from. That's both on a personal level and a professional level. The next step is science, which is to tell them what you know about the science and the evidence behind the vaccine in particular. And then last step is to explain or advise, which is to offer your recommendation about the vaccine. And this kind of helps to really get at people's concerns and try to address them in a way that's friendly and open. So we will go ahead and try to show this here.
I think I'm not actually going to get the COVID-19 vaccine.
Oh, can I ask why?
I'm young, I'm in my 30s, and I don't really even get that sick. So I don't think I need the vaccine.
Yeah. I used to think that too. A lot of people said that this was just like the flu. But I really learned otherwise, especially from working in the hospital and seeing even really young patients get sick and even die from COVID. I've also read a lot and learned that really all of us can get sick. Plus, we're at risk of spreading it to people that we love.
Yikes, that sounds scary.
Yeah. And one thing that we know about this vaccine is that it's over 95% effective at preventing COVID-19 disease. And almost all the time, it prevents really severe disease for people. So for you, even though you're young and healthy, I do recommend that you get this vaccine today.
All right, I'm in.
Great. We have a lot of references and we're happy to provide these to anyone who's interested in reading more and kind of what we learned about vaccine hesitancy. We also have some other resources to check out for trainings and information. And now we will take questions. One question is, can we share the slides? I am happy to share slides. Christina might know better about how we actually do that, but yeah, we're happy to share the slides.
Yes, the session's being recorded and the slides will be shared. So we'll have that posted and share out the link. Thank you.
There's another question about what does 95% efficacy mean? Will, do you want to talk about that?
Yeah, so it's a good question. So 95% efficacy here means that after patients receive the second dose of the vaccine, because it requires 2 doses, that they saw when they tracked the number of infections that occurred after that second dose in the placebo group who got, a placebo vaccine versus the people who got the actual COVID vaccine, they saw that there was a 95% reduction in the number of infections. So when they were looking, they saw over 100 infections in the group that got the placebo, and I believe it was fewer than 10 in the group that got the vaccine. And so when you do the math, that works out to be 95% reduction in, and furthermore, that's just in getting symptomatic infection. There was 100% reduction in both vaccines in severe COVID. So severe COVID meaning requiring oxygen or admission to the hospital.
Well, there's another question I think you could be helpful with. So this is getting at, I think the question is really getting at the difference between emergency use authorization and full FDA approval. So the question is, there's info on the handout sheet from Moderna that says the vaccine is not FDA approved, but the slide that we talked about FDA approval and going through all of the typical steps to get that. And so this kind of does, which actually, just so you guys know, there's going to be another presentation soon that's going to go through the product specifically and also talk about this emergency use authorization and what that means. But maybe, Will, you can just speak a little bit to that.
Yeah, so that's a good question. So right now, both the Moderna and the Pfizer vaccines are they've been approved for emergency use. And so this EUA, or emergency use authorization, means that a panel of physicians and scientists reviewed the existing data on the vaccines and determined whether they thought it was, safe, in the considerations of all the data that we have now, whether it was safe and effective, and on balance, it was better to start using the vaccine than to wait for the full approval of the FDA, which would require a longer period of study. And as both Brittany and Talitha pointed out, the vaccines have been, over the smaller clinical trials and larger clinical trials have generally been considered safe and well tolerated. And this early efficacy data on balance was enough to get that emergency use authorization. So in the coming months, I believe it's going to be April or May, Pfizer and Moderna will seek full FDA approval. And what that will mean is that they've completed their phase 3 study, which requires a longer period of time as designed. and then they'll submit all the data and documentation, and then it'll go through the full approval process.
Talitha or Will, there's a question about, are you worried that people may not follow up and get the second dose of the vaccine? And what if they only get a single dose?
Well, I can say that from my reading of that I know that has been out in the news, particularly in the last few days, even about possibly only giving a single dose, or if only people get one dose, what does that mean? And so what we can say is that the studies have been done on people who have gotten both of the vaccination doses. And so I can say that the evidence is based, that we know the data, being 95% effective is based on people getting both of those doses of vaccine. So there is less data, and I am not aware of any numbers specifically about the results if people only get a single dose or not. But I do think that that is a possibility, as it is with any sort of medication that we take, and we need to take it multiple times. Adherence and the barriers to that are definitely an issue to talk about.
This is an interesting question. Will, maybe you can answer this. Why are there two types of the vaccine? Why is there a Pfizer and a Moderna version?
There has been a large effort by many groups and many companies to develop a vaccine for COVID. And so they all took different approaches, and these two happen to be fairly similar in design. They're both mRNA based, but they do have some slight differences in kind of the underlying technology. Anyway, so we were rushing to get something to work, and so we took, basically we took 100 shots, and these were the first two that kind of got through the finish line. And we'll see more. I assume we'll see more vaccines get approval for use in both emergency use and then full approval as time goes on. But due to the unique technological advantages that mRNA provided, was allowed it to get really quickly through all these, to the clinical trial stage, and less time in lab.
There's another question. Can the vaccine be mandated if it's only approved for emergency use? This is kind of like an ethical question. There was recently a talk I was listening to on NPR from some ethicists discussing this. Most of them say probably it can't be mandated if it's under emergency use authorization. What they can do is say that, for example, if you don't have it, you're required to continue doing certain things that we're all already doing anyway, like wearing eye protection and wearing masks and those sorts of things. But you're right. I think it shouldn't be probably mandated and can't be mandated if it's only under the emergency use authorization. That's it. I think it's going to be FDA approved soon.
There's a question here that says, are there variations in effectiveness across different ages? And so the answer that I have to that is, it seems like there is a slight reduction in efficacy in older adults over 65. Both Moderna, I believe Moderna saw 87% efficacy compared to in their older adults, and compared to the 95 in the overall group. And Pfizer saw 94% efficacy, so very similar. But we don't have enough data to know for sure how, those are small groups in the older adults. So more data is coming in, but there's probably maybe a slight reduction in efficacy in older adults.
There's a question here about I don't know if Talitha, you want to answer this. What will you be telling patients who agree to get vaccinated about continuing to wear masks, maintain social distancing, and good hand washing?
I think all of those are still really critical. I think the idea of vaccination is that there is sort of a critical mass at which we would gain herd immunity, if you've ever heard that term. And what that means is that we've reached a threshold where the majority or a large portion of our society and people we interact with daily are protected against the vaccine by protecting the infection from the vaccine. And so once a certain number of people are vaccinated, then we are more safe. And maybe those measures that we are doing every day can be scaled back. But at this time, only a very small portion of our society is actually getting the vaccine, starting with, frontline healthcare workers. And so it's critically important to say that we're giving the vaccine and you still need to be wearing masks and maintaining social distancing and good hand washing, to help ensure that we're still doing every strategy we can to reduce infection, as rates are still incredibly high here in the United States and in the world.
There's two questions here that I think you can answer, Will. So can you still catch an asymptomatic or mild case of COVID after getting the vaccine and pass it on to others? And yeah, they're both. So can you get asymptomatic COVID infection and pass it on to others, even though you won't get sick, but potentially expose other people even after you've gotten the vaccine?
So that's still a question that we don't have an answer to yet. They're still doing studies. So the recommendation is people who get the vaccine should still wear masks, because there is a concern that they can still be asymptomatic spreaders of the virus. There are studies planned to try to address this question that we'll have data for later this year. And so based on our existing knowledge of how these vaccines would work, and other, kind of historical knowledge of vaccines, it's likely that there's at least a significant reduction in your likelihood to be an asymptomatic spreader, but we don't have a full picture yet, but it's coming.
There's a question about other differences in the prices between the two vaccine or the efficacy.
What differences?
Between the Moderna and the Pfizer vaccines, are there differences in cost or efficacy?
I don't know when it comes to what I think, I don't know, you may have a better answer to this than I do, but I think right now they're all being covered by various, federal and state grants. In terms of the cost of production, there are differences, but I don't think that matters as much to this group. And then what was the second part of the question?
Efficacy.
They're both, so Moderna reported 94% efficacy, and Pfizer reported 95%. So within a statistical margin of error of one another in terms of overall efficacy in the patients they tested. So I would say they're effectively the same level.
There is a question about how long does the vaccine offer protection?
So that's still a question we need to have answered. The earliest patients got these vaccines in March and April in the first phase 1 clinical trial. And following up on those patients, there are reports that they still have antibodies, which is the primary mechanism by which it's believed these vaccines offer protection, suggesting that they're still protected against COVID. So that's, that would be 8-9 months out from those earliest studies. But that's a very small group. In the larger groups, we're 6 months out, and they think that at least 6 months of protection will be offered, but probably over a year is what the best guess I've seen. But it's still an open question. We still don't know the answer.
There's a question about whether or not you can get the vaccine if you're undergoing chemotherapy, radiation therapy, transplant patients, or immunocompromised, and the answer is yes. Some of those groups, so solid organ transplant patients are, I think, the 1B categorization, and then other patients like hematopoietic stem cell transplant patients, I think, are in the 1C category. So those are prioritized patients. These are not live vaccines, and so they're safe for people who are immunocompromised.
There's a question about, are there other companies developing vaccines without the mRNA technology? And the answer is yes. AstraZeneca is probably the one that most people have heard of that's been in the news, and that they take advantage of an adenovirus to deliver the vaccine dose. So they repurpose another virus and make it safe to give to patients, and then it works as a vaccine. There are other groups that are trying to use the traditional methods where they inactivate the virus through different chemical processes and administer that as a vaccine. So there are numerous other approaches that are being considered. The mRNA ones were just the ones that got first through all of the clinical trial phases.
There is a question about what does the evidence show regarding are patients more likely to accept advice from providers from their own cultural group? I don't know that answer. I didn't come across that study that specifically answered that question in the literature. All of the work that I found on addressing vaccine hesitancy, honestly, all of the approaches were kind of like didn't have fantastic evidence behind them in terms of efficacy. And part of it is probably because it really probably depends on the particular community. But if anyone else has information to answer that question, please share it. There's another point here about emphasizing that there's similar efficacy between, I think this is related to the Pfizer versus Moderna when you get 2 doses, but not with 1 dose.
Yeah. So yeah, with 2 doses, they're both about 95% efficacy. They have about 95% efficacy. With a single dose, the best estimates, which the studies weren't designed to answer the question of how effective a single dose is, but they think that there is some protection. 70 to I think I saw 70 to 80% efficacy for both Moderna. I think Moderna was 80% they were estimating, and Pfizer was around 70 for a single dose. But again, the studies weren't designed to address single dose, and definitely getting 2 doses we know is better.
So another question is, can someone get the vaccine if they've been positive for COVID-19, and will the effectiveness differ? Will, do you know any data on whether or not efficacy is different?
I don't know off the top of my head. I can look that up while we answer some other questions and see.
Okay, we'll look it up. Yes, you can get it. But the second question is an important one. We'll look it up. There's a question, I don't know, Talitha, if you know about this, but the question is, what are the reasons why there are 5 million doses administered? There are like 5 million doses available in the US versus approximately 17 million doses being delivered. And are there opportunities to sign up to volunteer to administer in our own communities?
Yeah, I wonder if that question is somewhat about the discrepancy between how many vaccine doses there are versus how many are actually being given to people.
Mm-hmm.
And I do know that that's been one of the challenges that we've been facing in the United States is the actual delivery of the vaccines and the number of people who are getting the vaccine. And I think part of that is that the vaccines are being distributed to hospitals, and then hospitals right now are currently working on vaccinating their own staff. And so since it's a pretty fragmented approach to giving it to the different institutions, I think that's why it's been hard to actually ensure that more people are getting the vaccine. So I haven't heard about volunteers or signing up to be able to give that, but I love the idea of that. I think that that's coming as the vaccines are going to be able to be spread more to our communities, and our like government institutions will do more to help kind of administer and organize that.
I think that's a really good point, that, going to people where they're at is going to be a key part of this, and having people that folks trust, people from their own communities do it, I think will be huge. There's also a question about this is a vaccine for children. Do we know when and if one's available for kids and adolescents? So my understanding is the Pfizer vaccine has emergency use authorization for over the age of 16, and then Moderna is over the age of 18. There are currently studies to look at safety in, I think, age like 12, starting at age 12.
Age 12.
Okay. But we don't have, there's no reason to think that it won't be, but it's just very typical for studies to be done in adults first before they're done in children.
So to go back to the question that we didn't have the answer for, Yes, patients can get the vaccine even if they've had COVID in the past, and there's nothing to suggest that, especially in the way these are designed, that they would have any reduction in efficacy. Like the vaccine should be just as effective even if you had previously had COVID, would be my suspicion. But I don't think we have enough data yet of patients. There probably will be studies coming out, I would imagine, to answer that question directly. But just based on the science and how these vaccines work, I would expect that they would have similar levels of efficacy and boost natural immune responses that those patients would have already had.
And then I think just two more points here. One point was brought up that we need to really address side effects when we're talking to patients. Thank you, Dr. Cunningham. Yes, and side effects are mild, but they're expected, and so we shouldn't minimize that. We should tell people what to expect and what that could be like, and reassure them as to why those things are okay to have, even if they're uncomfortable. And then I think we have time for one more question. This is a good one. Will, I think maybe you can answer this. After someone has had COVID, how thorough and how long does natural immunity last?
So I think it varies based on the severity of disease. So it's going to vary from individual to individual. But one paper that was recently published looked at hospital workers who had COVID. And I think they looked at several thousand. I don't remember exactly how many. And they found an average immunity of about 6 months of protection after infection, but as short as like having no natural immunity. So I think, the vaccines are definitely going to be more efficacious for getting immunity in terms of protection than having COVID, and obviously, and so it's just going to vary a lot from individual to individual how long that immunity lasts after infection. But it looks like maybe 6 months, but we don't really know. That's a small. It's even though it's thousands of individuals, it's still a relatively small study.
I think we're at our time. Is that?
Yes, we're at time. Thank you all so much for this great presentation and all the questions being answered rapid fire. So we really appreciate that. And then we will stop the recording and we'll share out the slides and the recording with attendees. When I end the webinar, you'll see a link to complete a survey, and that helps us to learn from this experience and what you enjoyed and how to make it better. So thank you all so much. Appreciate your time.